Biggest difference between implants and retaining the tooth through root canal treatment is that implants. That's the big difference. Sometimes when you say to patients you'll be dealing with an implant failure in your lifetime, they look at you like, really? I thought an implant would last like till I was 100.
How long anyone's going to last on this planet. But in my planning, I plan to age 100. So I see everyone as living to age 100. And so my planning, I don't think this will make it. Therefore,
your health is within your own control also. It might be only 50%, 25%, but some of it's within your own control. I want the patient to go on holiday and not be sitting there worrying about whether their tooth might be bothering them and they have to go to a dentist and take antibiotics.
Endodontics versus implants. Is this even a worthy battle? Let's be honest, right? Any implant dentist worth their salt would agree that for themselves or their family member, where an endo is feasible and you have a good prognosis, that is the obvious choice first before having an implant, because an implant will still be an option for the future. And that's pretty much easy and unanimous in dentistry, unless of course your patient suffers from titanium deficiency disease. Now, where this becomes more pertinent is those dubious scenarios, lack of tooth structure, those nasty cracks. We particularly discussed these two scenarios, whereby perhaps we should be considering implants. But wait, Dr. Omar Ikram may have a few things to say about that and why we should be considering perhaps root filling retained roots, root burials, amputation, and a term I introduced called palliative endodontics. Why that might have a growing role so that we can defer implants, because we know implants do not last forever. Endo doesn't last forever. Nothing lasts forever. So it's important about seeing the bigger picture when it comes to longevity. Hello, Protrusive. I'm Jazz Galati, and welcome back to your favorite dental podcast. Every PDP episode, I give you a Protrusive Dental Pearl. Now, there is a theme in this podcast where we discuss about the age of the patient. We all know it's better to have an implant when you're 60 or 70 than when you're 40. And one thing I always did is when I communicate to patients, I was inspired by a consultant in restorative dentistry. Dr. Chanda used a line to a patient. He said, look, I don't know how long anyone's going to live for, but I always plan my dentistry to age 100. And I've been using this line to my patients, and yeah, it's okay. It works well. They get to see the bigger picture. But a lot of patients can't relate to that. A lot of my patients, they're 60s, 70s, and 80s, they just can't relate to that. They immediately start thinking off topic and thinking, oh, I probably won't make it. So one of the changes I've made in communication based on what Omar discussed with me today, and really the pearl I want to pass on to you, is instead of saying to age 100 for everyone, look at your patient, let's say they're in their 70s, and then you want to say, look, I want this to last well into your 80s, maybe into your 90s. Now, they may still think, oh, I probably won't make it, but it's just a bit more relatable than putting a number age 100, because chances are most people don't know a 100-year-old, but they might have friends in their 80s and 90s. Do you see what I mean? Obviously, it's a very niche scenario, but me personally, I have a very aged population that I look after. My patients on average are 60 plus. And so this change in terminology and the way I communicate to patients in terms of longevity of treatment, I think is going to really help me to get the point across, well into your 70s, well into your 80s. And you'll hear this again in this episode being a big part of today in this episode with specialist endodontist Dr. Omar Ikram. Before we join the main episode, have you downloaded the app yet? The best way to do it, if you haven't already, is visit the website www.protrusive.app. Once you're there, make your account. Then once you made your account, you could download the iOS or Android app and log in to find the nicest and geekiest community of dentists in the world. What I found is that dentists join the app for the content, the premium notes, the transcripts, the Protrusive Vault, our mini masterclasses and courses, just a better overall listening and watching experience. But what they stay for is the community. What they find is that they fall in love with dentistry all over again, because dentistry can feel so lonely and isolated. And on some of these social media groups, you get shot down when you ask for opinions. But really, we've brewed a culture, but very hard to brew a culture of kindness, being considerate, and selflessly sharing information. So remember, the website is protrusive.app. The app is called Protrusive Guidance. I would love to see you on there. Let's join the main episode with Dr. Omar Ikram. And at the end, of course, you can answer the quiz to get your CE credits on the app. Omar, welcome back to the show. I just saw you post on Instagram. So you were on the bike doing a marathon. Tell me more about that.
I know, it was just one of those big days at work and I was doing an extra bit of punishment for exercise. I tend to do this to myself when things get tough. I think, what's something I can do for 20 more minutes? You've had that big day, you think I can't do any more, and it's like, you can do. And by doing that, what you're doing is you're just pushing yourself that extra bit and saying, you know what, even those hard days in clinic, I can still do a bit more.
I love that. It reminds me of a book, the David Goggins book, Can't Hurt Me.
Yes.
Have you read that one?
Yep, that's a favourite of mine. That's a good one.
I mean, exactly what you're saying. It reminds me so much of that. So I like your life philosophy.
Yeah, and it's a good one. I mean, basically, he talks about callousing the mind, doesn't he?
That's it.
Making yourself more determined and thinking you can push yourself a little bit further all the time. And what you do is then you grow. Because if you just sit back and take things easy, you basically don't grow. You just stay static. And we all know many, many people who have done this in our lives. There are people I know who are still working like when the day that they graduated from dental school. And that might be fine for those people. I'm not saying anything wrong, but they haven't grown. And sometimes those people aren't enjoying dentistry as well. And I think to myself, but you haven't given it a chance. And it's just little incremental growths. You know, I've been graduated now for 27 years as a dentist, and it feels like forever. But, you know, if you do those 5% growth in 27 years, there's a lot of growth.
Well said. It's a theme I cover a lot on this podcast. How do we figure out those very engaged bunch in dentistry who say that, yeah, they absolutely love dentistry, right? And then those who are disengaged and not enjoying it. And I think of the several factors, one is your mindset, but in a way that you have that growth mindset, you have that abundance mindset.
Yes.
Like, okay, you want to keep giving back to the profession. There's more to learn. And I think if you see it in that way, then you don't stay stagnant.
That's right. I think that you have to think to yourself sometimes, dentistry is a long haul, like it's a long game. Yeah, we all graduate, we all want to get busy. You know, I see it a lot with younger dentists. I want to do what Omar's doing. It's like, that's took 27 years. Just be enjoying where you are, and you will get there. If you keep enjoying, you will do far more than me, you know, but you will do lots more than anyone. But you do have to keep doing those, you know, 5% growth per year, 6 or 7% growth. You'll have to be committed to that. And I know life will get in the way. I sometimes talk to my friends and I say, life will get in the way of your dentistry. And, you know, this is where your team around you, the people around you who are supportive, maybe your parents, maybe your partners, maybe your children, are part of that progress. Because if they hold you back, then you won't progress. You know, there are a lot of people I know, again, who have seriously big commitments with their family and things like that, and that will just stop them progressing as dentists. I'm not to say that they won't be great parents or great partners or whatever, but it will hold them back in their dentistry. And that's something we have to all be thankful for. I mean, sometimes I think to myself, you and I are in the place we are because of not only what we do, but what our partners and kids and family will allow us to do, and fortune. You know, we're caring for people who are sick, and we will be less involved in dentistry. And also the generations that went before us that didn't muck it up for us. You know, they laid a platform for me to go to university. If I didn't have that platform, I wouldn't have been able to do it, and I wouldn't have been able to do what I'm doing now. And you have to be really, really thankful for that. People that you probably even met, you know, decades, I'm talking 50, 60, 70 years ago, people will have been doing things the right way to enable you to have the platform and the start that enabled you then to go to university. Also, they set almost from the grave or from the past, they set you a benchmark. Like, for example, I have a grandfather who was heavily involved in partition, India and Pakistan. And for me, I never met him. And I look at his picture with one of the people who came up with the concept of Pakistan. And I think, wow, this guy was right there when they created Pakistan, and he was involved with the people who were doing all that. And I think to myself, I never met him, but I would have liked to have made him proud. And that is something quite amazing when you look at past generations, even though you never met them, and think, and they laid the platform for me to be able to do it. And then you should pay that forward as well for other people. It might be your kids and your partner, of course. It might be your patients, of course it's your patients. But sometimes I think to myself, and what else? And what about colleagues? What about that dentist who came to me on the course on Wednesday and said, I've got serious depression. I'm like in a really bad place. And I said, look, if you can get the grades to get into dentistry now, and you can battle with that, and you can enjoy dentistry, you will actually be able to do anything you like. It's just a matter of you being able to see that. You might not be able to see it now, but if you keep going, you will be better. And then the sky's the limit. You'll get to a point where the obstacles that we all come up against, you know, the costs of living, making your practice, you can list, 100 barriers we'll all come up against. The ones that you're able to break through or leap are the ones that many others won't. And every time you come up against a barrier, if you can leap it in style or gracefully leap it or whatever, then you will become better for it. And many others won't be able to do that. So, and then you'll get to a place where you'll realize that the sky's the limit. Like after that, you're definitely there with this podcast, I'm sure, but I'm just getting to the stage where I'm thinking to myself, what I want out of the last, 20 years or so of my career. I don't know how many years I got working in dentistry, but I'd love to keep going as long as possible. But there was a time where I wanted to retire early because I thought dentistry was really hard. But now I don't have that thought at all. I think to myself, let's keep going with this positivity and fun. It's a massive part of my life now.
like I said, it's a mindset, like the philosophical start that we've had, Omar, to this podcast. I mean, 3 little reflections based on what you said is the book Outliers argues exactly what you said, that actually it's not just rags to riches in terms of hard work and determination. You need so much more to go in your favor. There's a reason why both Steve Jobs and Bill Gates were born in 1955. There's a reason for that. Because when they were 17, 18, they weren't old enough to be married commitments. They were young enough, enthused enough, and they both were early adopters of being lucky to be in a home that had a computer kind of thing. So, and then you paid homage to your grandfather. So that's great. So Outliers, that book. Then it reminds me of a Mark Twain quote. It took me 20 years to become an overnight success. And then the last one to point out is everyone's got a plan until they get punched in the face. And if you get punched in the face, you may need an endo. And therefore, we're talking about endo or an implant, because we're talking endo versus implant, right? So this is like a big debate, right? On one side of the ring, we have endodontics. On the other side, right, we have implants. And quite commonly in conferences, I see this as a very popular lecture title. And it's great. And I think there's space to discuss more about it. And I guess the elephant in the room, Omar, first, excuse this little monologue, is there is a bias, right? You are an endodontist, okay? So we kind of know what the ding, ding, ding winner will be at the end. However, I don't know a single implantologist worth their salt. If endo is on the table as a viable option, I don't know a single endodontist worth their salt who would opt for the implant when the tooth is still a viable option on themselves, on their patients, on their daughter. And I think some of the themes I want to discuss with you is feasibility, okay? Why endo for an implant, but then what makes it unfeasible? What are the red flags that we should be thinking, actually, this endo will not be predictable and we should be then going for an implant? So I guess where I want to start is, what are the complications of extractions and implant that we want to veer away for? And we'll build on, okay, well, how can we do more endo and when is endo appropriate?
That's a really great start, because I had this down, and I think the biggest thing we have to think about with regards, I'm going to start with what I say to patients now. I used to say, like we all did, you've got an infection in your root canals, you could take the tooth out or you could replace it. That's not the right thing to do at all. That's what they teach you at dental school. It's totally not the right way, because every patient is different and every tooth is different and every scenario is different. The smart clinician will actually be able to work out what's right for that patient because of certain factors. So what I say to patients is, our teeth are supposed to last for about 24. And everyone says, what are you talking about? Teeth are supposed to last for 80 and 90 years. But this first molar comes through when you're 6 years old. The second molar comes through around 12 years old. And the third molar comes through around 18 years of age. So you add 6 years, that's 24. 24 is also the years where we look at implants as a maybe an option because the patient's stopping growth. And 24 is probably about the life expectancy of a human being in a world where we don't have tribes and we don't have farming and we don't have, roads and all those things we have now. So in order to keep your teeth going way longer than 24, because people live in the developed world to about 85 in Australia, 83, 85, depending on gender. Women last longer. They live a longer life, apparently. And basically, if we're going to keep people's teeth going instead of just 24 or so to 85, we're going to have to create something that's not normal. And we've done that with longevity, with heart bypass surgery and valve replacement and, brain surgery. And you can list all the medical advances which aren't supposed to be done to people that's kept them alive. We have to do the same in dentistry. We're keeping a tooth around longer. So that's going to involve things like root canal treatment, possibly. And that's going to extend the life, not keep it till you're 95 years old necessarily. So to get back to your question is to say implants, the biggest difference between implants and retaining the tooth through root canal treatment is that implants don't have a periodontal ligament. That's the big difference. And then patients sometimes look at me like, why is that an issue? And I say, look, when you bite on a tooth, the ligament moves like it does in any ligament of any muscle when you're lifting weights or whatever, to tell you that the bone has to remain there. You don't have a ligament, you don't have that connection with the body, you don't have bone retention. The tension in the ligament keeps the alveolar bone present. If you have a denture on the ridge pushing down after you take the tooth out, then the denture will actually resorb bone, because it's like your wedding ring on your finger. Compression will resorb bone. The implant won't prevent food pressing on the ridge, so that will prevent the bone resorption being fast, but the bone resorption will happen because there is no ligament. And so sometimes I'm saying to patients, look, implants last between 15 to 25 years. That's a really good implant. Obviously they can fail straight away and all those things. That's something that can happen. But if the patients say under 60, I say to them, you'll generally be dealing with an implant failure in your lifetime if you take the tooth out and replace it. If the patient's 65 or 70, sometimes I'm saying to them, look, an implant will last you into your sort of mid to late 70s, 80s. It's a possibility you might replace it sometimes, like depending on the tooth, of course. As you said before, if a tooth's restorable, it would have a root canal treatment, but then what is restorable is what's possible, and it's based on your skill of not only endo, but restoring teeth. And the problem is many endodontists aren't amazing restorative dentists necessarily, although I think you've got some really great ones there in the UK for sure. And also many general dentists don't want to do the endo. So it's that kind of new kind of situation where we have restorative endodontists who do good endo and then they do good core and restoration of the tooth, because restoration of the tooth has the most impact on survival of the tooth and longevity. So if you do a great endo and chuck a temp in, it's going to be way worse than if you can restore the tooth and then set the crown up for the general practitioner or whoever's doing the crown or the cuspal coverage. So what we're saying here is really the periodontal ligament is really the main factor. And so I'm talking to patients now more and more about this, but there's also other things that you've got to bear in mind with implants. So just to get you started on a few of these. So the obvious ones, the ligament's going to be lost and it won't last forever. It'll probably last between 15 and 25 years. And that's good enough for some patients. Some patients, as I said, if they're 70 and the tooth's really in a bad state, well, it'll probably last to 85 or 90 with the implant, maybe. The other thing just mention is that I never ever now say, take the tooth out and replace it with an implant. I go to someone for an opinion. Unless the tooth's like cracked down the middle. There's a few, probably get to this, red flags, but there are a few situations where you really cannot do endodontics because the tooth's structure is totally destroyed, and that's a red flag. But like if the tooth is half viable for anything, I often say, look, I wouldn't opt for root canal treatment as the first option here. The tooth structure is bad, or you're in that age group where an implant may last your entire life into your late 80s, 90s, etc. Depending on the patient. I mean, if the patient's well and healthy, they've got a good family history. Sometimes I'm talking about family history of longevity and they're saying, oh, but my mother lived till 100, and I go, well, maybe we keep the tooth, maybe it won't last your whole life. Things like that. You have to be a clinician. You have to talk about these things. Doctors talk about it, and why not dentists then? The other thing we're looking at here is medical history. Again, some of the antidepressants have like 4 times the failure rate. You'd be surprised about 4 times failure rate with implants.
Do we know the mechanism of that, antidepressants and implant failure? Do we understand the mechanisms of that yet?
Well, there is some theory on this. It's got to do with basically the bone interactions with the medication. Yeah, it's not really well understood, but basically there's this research showing that it's the SSRIs, or the serotonin
selective reuptake inhibitors.
Correct, those ones, yeah. They're basically the worst ones. So, if a patient's taking that, talk to them about not having an implant because there's problems with that. The obvious ones come up. Yep, correct. Bisphosphonates, and also not only bisphosphonates, but are you in that category of patient who may need to take bisphosphonates? Have you got osteoporosis that's early and things like this?
Or in the family.
Yep, in the family. Are they a female patient who get osteoporosis maybe a bit more than males because of the physiology? Smoking, obviously, diabetes are the obvious ones. Oral hygiene, those sort of factors. So things like bisphosphonates, again, very important to say. And, if you're about to start bisphosphonates, well, we need to start maybe doing the implant or not. Again, an opinion before we do anything. I'm doing that a lot nowadays. Go for an opinion. If he says or she says what you want the specialist or the dentist to say regarding longevity and it's going to be wonderful, then do that. But I can do something for you, but I'm not saying it's the first option all the time. So I almost never say, just take the tooth out. It'd be rare.
But this is the conversation that the general dentist has, right? You're putting yourself in the shoes of the general dentist. The message you're giving to listeners is try and get an opinion just in that middle category and you're unsure from the person who's going to be doing the more complex job, the implant or the endo.
Yeah, so what happens is the patients often come to me from a general practitioner. The classic one is external cervical resorption, central incisor. Can you save it? And the answer is, well, I can sometimes, and sometimes I can't. And again, we'll talk about that maybe in a few minutes about the red flags for endo. But I'm often going, well, if you're under 60, we need to keep this tooth going till you're into your 60s. That's I often say, well into your 60s and beyond would be wonderful, but into your 60s is where we want this tooth to last till. Then an implant lasts 15 or 20 years and you're sort of nearing 80s. And then you have a fixed bridge option. The bridge option should be the last option because they use the teeth either side to hold it in. You're going to damage those teeth, and maybe if you're 90, that's not an issue. Certainly it is an issue if you're in your 40s having a bridge, because we know that's going to fail. The abutment teeth will fail. You'll have root canal treatment on teeth just because they were there prepped to hold the tooth in, to pontic in, all that sort of stuff. So you do not want bridges in young patients, but in an older patient, maybe it's fine. So this is the sort of way I go, is like implant implant that fails, if you were in sort of late 80s and that failed, then a bridge, and that should keep you going well into your late 90s. And then we've done the things that I was talking about that extend the life of having a fixed tooth there. And I think that's the key, is like, look for that fixed option to last forever. Sometimes when you say to patients you'll be dealing with an implant failure in your lifetime, they look at you like, really? I thought the implant would last like till I was 100. And it's like, no.
Everyone thinks that, right? Spend that money and they expect it to last forever. And so we need to give them that dose of reality and expectation management. But you're saying that specific case of, let's say, the cervical resorption, and you could save it, but then, who else's opinion would you seek?
Yeah, so if the external cervical resorption is really severe, then I'll often get the patient to go for an implant consult or opinion. And again, I say, look, if you're in a situation with a person who is going to do the implant, so this is going to be a great result and it's going to last for 20 years, maybe you'll take that one, because what I can offer you sometimes isn't 20 years. What I can offer you might be like 5 to 10 years, maybe. It depends on the severity. External cervical resorption is one of those really difficult ones where it's like, could be just a restoration and it could be like completely gone. By the time the patient gets to us, often it is completely gone. They've had external cervical resorption for many months or years, and the tooth is asymptomatic because, as I explained to patients, your immune system is removing your tooth, and we have no inflammatory reaction against our own immune system. And basically, the immune system is burrowing into your tooth and actually protecting your tooth from the bacteria in your mouth. So the immune system's in the cavity protecting your tooth from the bugs, so you don't get bugs using the hole in your tooth as we do with caries or cracks, because the immune system is removing the tooth but protecting it at the same time. But you get to that point where it's symptomatic and it's like the hole is so big now the bacteria can gain access, and that's when you have the problems. And it's like, so now the tooth's like really in a bad state. I have to say, if I have a tooth with external cervical resorption with pulp necrosis, it's usually not looking too good. That's how I generally would judge cases like that. If it has a vital pulp, even if the structure is quite compromised, I'm usually more keen on saving those teeth. But it's a sliding scale with external cervical resorption, and thankfully we have CBCT, which is such a good tool for showing the patient, look, half your tooth's gone. It's not there's a 2D radiograph. So I've been doing a few cases like this recently. But holding on to teeth with external cervical resorption is very difficult. Quite often they need crown lengthening and surgical treatment of the resorption as well as root canal treatment, and it just kind of adds to the cost. And again, you need to justify the cost for the patient, because if you're spending the same or more than an implant in private practice in England, I'm sure, and the implant is the same as a crown and a root canal treatment, and if you chuck a surgery for the external cervical resorption, then it's possibly more. But if you can say to the patient, and the reason why we want to keep this tooth is the implant will fail in your lifetime, then they're all more on board with what you're doing. I found this changed my messaging from when I was a new grad going, yeah, it'll last like 15 years, and you have no experience to tell the patient that, because that's what some of the papers say. They say it lasts 8, 15 years, 10 years survival is very good, even 20 years survival. The Eckerbomb paper is like in the sort of 74%. You're using these kind of stats, but actually what you need to do is work out if that patient does need the tooth for that long. Then you're looking at the patient. An 85-year-old doesn't need the tooth for 15 to 20 years. That's generally how it goes. And as patients age, different things come up, like maybe they can function with just premolars, and there's a whole heap of things that come up as you get older that totally change.
How do you deliver that message gracefully, Omar? Usually if I say to an 80-year-old patient that, hey, I'm going to do this, and I'm usually the first one to say, okay, I think this has a really good success rate, 15, 20 years I can expect from this intervention, and I usually wait for them to say, and they laugh it off, say, I probably won't be here at that point, I'll take that option, kind of thing. So rather than me saying, you probably won't be here at that point, therefore is it a graceful way to communicate that?
Yes, I totally learned the hard way, as everyone does. I never say you won't be needing it. You say it'll last you well into your 90s. And as you said, the patient usually says, but I'm not going to probably live till I'm 90. And I go, well, that'll last you a long time then. But conversely, what you're often doing, I find nowadays, is I'm taking patients who are under 60 and they say, you're 55 years old. In my books, that's a young patient. And they look at me and go, what do you mean? I go, yeah, because most people live till 85, 83, whatever it is. You've got many years chewing ahead of you. I mean, I know you don't think that way, but realistic, you do. That's the way the average life expectancy works in this country. And so by retaining...
One thing I learned, Omar, is, sorry if I'm saying, is one of the consultants I work with, Satinder Chanda, he said to patients, I can't predict how long anyone's going to last on this planet, but in my planning, I plan to age 100. So I see everyone as living to age 100, and so my planning, I don't think this will make it. Therefore, to get you to age 100, here's my plan. Plan A, plan B. And I just feel like that's a really nice way. Look, you can't predict anything, but I'm going to plan to age 100.
That's a tough one, being an endodontist, to plan to the age of 100, because a lot of the time we're dealing with such broken down teeth, cracks and things like that. It can be difficult. I usually say around, 85 80, 85. I don't actually say that. I sort of say, if we can get the tooth to last well into your 60s and beyond, that's what we're aiming for, and an implant would then last you.
I think that's more realistic. A lot of time when I said that 100 line, patients raise their eyebrow. I was like, well, I can't relate to that. Do you see what I mean? So I quite like your way more, like, depending on the age of patient, into your 60s, into your 70s, into your 80s. I think that just has a bit more realism. So I actually like that more. So let's talk about the red flags, right? So for example, one question I had is, let's say you have a lower molar, let's say a lower second molar, classically split tooth or a cracked tooth going from the mesial marginal ridge all the way to distal marginal ridge. You start exploring the crack. Let's say it has an MOD amalgam. You remove the amalgam, and then before you access into the pulp chamber, you already have a crack that you can see running from mesial to distal, but it's above the pulp chamber, right? You haven't actually gone to the pulp chamber yet. At this point, are you committing to a tooth that actually, no, I can see this crack here. At this stage, is it, oh, this tooth is not savable? Or do we need to do our due diligence and explore into the pulp chamber and confirm there as well?
That's a really great question. So I've got a couple of really useful comments on that. If we've decided to go ahead with saving the tooth, and you've had this conversation with the patient about, age and what we want to do, we're saving the tooth because we want the tooth to last well into their 60s or whatever the reason is. We've got the patient on board. And I think this has been a really important thing with me, and the way I communicate with patients in the last few years is that the patient is on board to save this tooth. Firstly, as an endodontist, they're in my chair, so they wanted to save the tooth. If they didn't want to, they maybe went for the implant straight away or the extraction or whatever with the general dentist, or come to the surgery, didn't go for the consult. But when you start exploring that crack, there's a couple of things. First of all, CBCT will show you that if there's any periodontal defects. If the periodontal defect's deeper than interproximity and you can't probe it very easy, if it's deeper than 5 millimeters, it's pretty much game over, because they're going to have a periodontal disease there even when you do the root canal treatment, because that's essentially impossible to clean, regen and all that stuff. But if there's no defect deeper than 5 millimeters,
this is a clinical measurement or a CBCT measurement, what you're saying here?
I measure on the CBCT because often you can't probe between their teeth. Yeah, so assume that if it's 3 or 4 millimeters, let's say, but you can't probe it because interproximal.
And just for clarity for the younger audience, are you measuring from the CEJ to the bone crest? Where is this measurement being taken from?
Yeah, CEJ.
CEJ to the bone level.
The depth of the pocket, yeah. You measure on the CBCT because a lot of the times you cannot get the probe into proximal and probe it and measure it. And sometimes even with those 3, 4, it seems like less, It's not that deep. I mean, obviously you got the deep pocket all the way to the apex, then it's gone. I mean, it's obvious. But what I'm saying here is you see these defects and you go, there's going to be a crack involving the bone. Next question is, how deep is it? If it's 5 millimeters or more, then they're not going to be able to clean that, and they're going to do the best endo in the world, and this is going to be gone because of periodontal abscesses, and they're still going to get pain. They're going to get that swelling of the gingiva and all that stuff. They can't get their toothbrush out and clean down that defect. The next thing you go is on vitality. If the pulp's vital, that's a good thing, because vitality is actually something that means that the crack is not causing necrosis. So if the crack is not deep enough to cause necrosis, then the pulp will have warned the patient of pain, and the crack is early. The pulp's like an early warning signal. If we have that intact, we have an early crack. If we don't, then the crack could be anywhere, and it could be like a hairline down past the root. And even though there's no pocketing now, there might be in 3 or 4 months' time, and maybe it's not worth it. So vitality is the big one for me.
Vitality is good. It makes sense there because, if it's necrosis, it's too far down. But what about that middle ground of irreversible pulpitis? Something that I understand that as GDPs, we might see more than new endodontists, right? We see the irreversible pulpitis come in at that stage, and we can see that it's clearly a crack that was the etiology behind this. At that stage, are we at a crossroads, or is that, again, we're putting that in, we're still probably okay because there's still technically vitality?
Okay, this is a really interesting one, because if you get to that sort of stage and you're looking at irreversible pulpitis, well, firstly, irreversible pulpitis is actually vitality as well. So that's good, but that's a positive. But the other thing is that don't forget that you need to then start looking at the patient's occlusion and why they have a crack as well. So you start bringing that. But sometimes I'm seeing patients and I'm, look, you don't have any molars on your left side. The right hand, lower right, first molar is cracked now because you don't have any lower left molars. And we need to hold on to this tooth. We need to hold on to the lower right first molar because we want to maintain it, because you've cracked it, and you'll crack other teeth if I recommend extraction. I mean, there is a limit, as I said, with periodontal pocketing and necrosis and things like that will sway me to extraction. But generally, you're trying to now justify why you're keeping the tooth if there's a crack. You're basically justifying the exploration, I would say, is the best way. Because sometimes you don't need to explore much more than that and go, look, it's just not going to be worth it. I mean, if it's necrotic and there's a crack there, I'm starting to look at. Having said that, I often often clean out the root canals, obviously, to get rid of the infection and then seal it up and say, look, sometimes with those necrotic cases, maybe just keep managing it. It's not worth finishing, but maybe just keep monitoring it, and then when it starts to bother you, have the tooth out. But plan to get the opinion now, and then again see if you want to do it soon or whether you want to do it later or it fits in with your job. But I've got into a stable state where the tooth is now cleaned out and sealed. The crack will obviously open up at some point, but it might take a few weeks or months. Then you have a bit more time.
In this scenario, to what extent of your endodontic protocol are you carrying out for disinfection? Obviously, you're not obturating with GP. You're just hypochlorite. Are you doing any shaping and any long-term medicament?
Yep. I'm shaping with rotary or reciprocating files I like for shaping. Something smallish, but not too small. I like 2006, 2007 as I suppose 2007 Wave 1 gold sizes. Something that's quickly going to get down there but produce a shape that you can kind of clean out. You don't want to go for like a small file that's kind of like, then you have to use another file, a whole heap of files, when you're going to tell the patient their tooth's not going to be completed. You want to quickly clean it out to a certain size. I like, as I said, 2007 Wave 1 gold is kind of something that resonates with me. Clean it out, fill it up with calcium hydroxide, seal it with IRM. That's my favorite seal because of the antibacterial activity, and it's got that sealing effect. You know, IRM is a wonderful material. I think in Australasia it's not as popular as it is in, say, the UK, and since I trained in New Zealand and in England, I have both sides of the coin, and I have to say IRM was loved over in the UK. You know, it's such a good material. It is used for apical surgery, or was in the past before we had MTA, so that's how good it seals. It can be used as a retrograde filling, and it works. And so basically seal it up with IRM and then put a little GIC on the top or something that's going to last a bit longer, and then say to the patient, look, I've stabilized it for your trip or whatever, and then you'll need to have the tooth out because it's cracked really badly. And often I show them pictures, and that's quite handy, just go, look how badly tooth, because the patient will often go away and go, but it doesn't hurt anymore and there must be no problem. It's like, no, there is a problem because structurally this tooth isn't good.
Hello YouTube Protruserati. I know you're watching on YouTube and I hope you're enjoying this episode so far, but I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through Protrusive.app. So our best deals and free trials are only on Protrusive.app. Of course, we always put the link below in the description. And thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode. In Singapore, Omar, I came across this term from an endodontist and I loved it because essentially what you've described, and I say this to my patients now, is palliative endodontics. This is a palliative root canal. Patients get it in that very niche scenario. I appreciate it's a very niche scenario. And I'm sorry if I distracted from the lovely point we were exploring about that scenario with the cracked tooth. You mentioned the CBCT, you mentioned a great guideline about looking at the CBCT. Now, one thing worth mentioning is even with the best resolution CBCTs, we still can't see the cracks, right? They're still not good enough to see the crack. Am I right in saying that, right?
That's pretty much correct. The problem is a lot of the time what we're dealing with is we're dealing with a lot of scatter and we're dealing with a lot of beam hardening and everything looks like a crack, and then you can sort of mistake the real crack for the actual beam hardening or the scatter. There's a lot of that going on. So reading CBCTs is actually quite a skill. But what we're looking for is the bone defect. We're looking for that little, I call it a Pac-Man bite, or a little bite out of the bone in one area. You know, if you've got periodontal disease, the area is broad. If you've got a wisdom tooth that was removed, say it's a distal of a lower 7, it's broad, that somebody's taken the bone away, the pericoronitis has caused a periodontal defect. Essentially, it's broad. If you've got one little tiny bite out of the bone in one area, and you can see that on the axial, so the axial scroll down, it's like a little dark area just goes down the root, but it's like a semicircle, then you're pretty sure. And often I will correlate that with the GDP's pictures they've sent me. So the nice referrers that I have here send me a picture and go, this is where the crack was, check it. And then you go, well, that correlates with the crack that they're showing in their picture when they open the tooth up with the CBCT, and this will be gone. Having said that, as I mentioned, if it's a lower 7 or something, there's no tooth behind, there's no food trapping. If the patient's quite elderly, do you want to joggle the tooth along for a few more years? You know, if it's not that 5mm defect, I'm often saying it's up to you. You can try and save the tooth. It won't last forever. Again, what I was about to say before I got onto this subject is that second molars are such a big talking point as far as retaining versus extraction. So this is where we're going with this scenario. You know, they're also the most cracked teeth around. So you're often saying to the patient, look, you know, again, if you're sort of an 80-year-old patient or whatever, maybe take the tooth out, it's cracked, you can function with the first molars, no problem. Or sometimes just saying, look, you're under 60, the tooth in front, which is first molar, it's going to get a lot of wear and tear if you take the 7 out. If you take the second molar tooth out, it's going to be solely it's going to be the terminal tooth in your arch for the next 30 years or so. That will mean that you lose that tooth before it should be lost if you have this tooth out. The other thing I'm commonly saying to patients now is if you think about a first molar that's heavily restored because it's been there since the patient was 6 years old, maybe it's had a crown, maybe it's had an endo, ask the patient, even though you're looking at the second molar, ask the patient how long they've had that 6 or the first molar root filled for. They'll say 15 to 20 years, and you go, look, that life expectancy for the tooth is coming up, and you need a bridge option. Sometimes if they're an older patient, you may need a bridge option when you're older. You may go for an implant, but you may need a bridge later. So you have to preserve the second molar tooth, because the bridge option won't be an option if it's not there because you took it out on the whim. If you took the second molar out one day because you were feeling it was painful and you weren't sleeping and you just felt angry, you will lose the option of a bridge later in life, even if it's like when you're 75 or 80. You won't even have it there. So I'm talking a lot about this with patients, like, you know, look at the first molar, see what the restorative plan is into their life, and then work from there. The second molar is a good one because often second molars can't be replaced with an implant, or dentists don't want to replace that tooth with an implant because they don't see value. Obviously, oral hygiene is difficult in that region. All those things. Bone, higher forces, maxillary sinus, close to ID nerve, if you're talking about people with high ID nerves and things like that. There are problems. So I often say to patients, there won't be many dentists who will place an implant in this position. If you have it out, then that's the end of that tooth forever in that position. I'm not saying it's necessarily the main tooth because that's your first molar and that's what you really need, but you will lose that option of a bridge forever when that's gone.
I like this really idea of looking at the adjacent teeth and trying to talk sense and this logic that we're talking about them. They can really apply it to themselves much better. Personalized care, and that's at the crux of it. So can we just do a little quick summary of the red flags where, you know, you put your hand up and said, you know what, palliative endo is technically always an option in a way, right? As long as you can get some sort of seal. So putting palliative endo aside, in that we can actually deem this endo palliative because we can't get you a reasonable result because Okay, well, lack of tooth structure is one, but that doesn't mean you can't do palliative. You can still clear out the infection and put some sort of material there, and there's benefit in preserving the periodontal ligament even for the future implant, right? So tell us about that, retained roots actually. Maintain, because that was one of the questions I sent you in advance. What do you feel about retaining roots that are root fill so that in the future it's more timely to have a procedure or an implant in the future?
Yeah, that's a really good thing to do. I mean, if you can maintain alveolar bone, that's going to be a good thing. It maintains the width and the height. That's important to mention, is that with implants, you need width. You don't want a knife edge ridge to put an implant into. It's just not going to happen without bone grafting. And bone grafting is another procedure. As I say to many of the patients, sinus lift is another procedure, bone graft. These are all procedures that are going to make the implant more costly. And, I think most people who place implants want to place implants in the bone of the patient, not grafted bone. It's much better. It's better to place it in the patient's bone. So I think retaining roots is definitely a good way to go. If you can, root burial is what some people do. For those pediatric patients where it's like you've got an unrestorable central that's been smashed by an accident or trauma, or even resorption cases where you're like, oh, well, it's so resorbed, it's not going to be able to be restored, then maybe root burial is something that you can do with endo or without the endo. I mean, sometimes if it's vital, you can just bury the root.
And when you're doing that, is that something that you've done much of, either in your training or I don't know if it's commonly done in private practice? One of those things, isn't it?
I have done it for patients who are on bisphosphonates, and not in the sense that they're going to get an implant, but that they're going to retain the tooth and not require extraction. And what was really interesting about those cases was that these patients actually end up with, you risk assess the patient before you recommend for extraction. And so when I was working at the dental hospital, many patients were coming in and they had bisphosphonates, they had previous episodes of bronze or osteonecrosis. Moronge. And the other thing is spontaneous episodes of osteonecrosis. So they might hit their, lingular of the mandible with a toothbrush, or even the alveolar ridge at behind the tooth, retromolar region, and then all of a sudden come to you and say, I've got this kind of ulcer that isn't healing. And you look at it and go, that's not just an ulcer, that's spontaneous osteonecrosis due to bisphosphonates. Those patients, you need to prioritize keeping root stumps and things like that, because they're high risk of getting a osteonecrosis from removal of the tooth. Complications, I would say. But, if they're taking lower level bisphosphonates, taking them for less time, haven't had all these things, then you can sort of risk assess and say, look, if they follow the various protocols that we have for extraction, you'll probably be okay. So I always risk assess the patients like that when I'm talking to them. So maintaining the root stump sometimes is necessary. The other ones that come up with obviously previous radiation therapy patients, where I remember there was a patient from overseas who came, and my oral surgery friend said, this woman needs her teeth retained. She's got literal radiation burns from the radiation treatment that they've done for her head and neck, will be very, very susceptible to damage. You're going to have to do it. So I ended up retaining those roots. It's very hard. You end up, clamping the gingiva with the rubber dam. Then you end up getting some coronal seal, which you hope is enough of a seal, because we all know that's so important. But yeah, they go from there. I used to do that more, I'd say, in hospital dentistry.
That's what I would have thought. Now, I've got a similar scenario. Lovely gentleman who I've been seeing for 5 years now. When I first met him, he did have oral cancer in the past. He had a radiotherapy on the side of his face. And we decided together with an endodontist that, okay, it's really important we avoid the extraction. And so essentially he did a palliative endodontics, okay? He managed to disinfect. In a couple of the canals, he managed to put some GP. In the other one, he put some calcium hydroxide. And what we've done over time, I believe he just either put some IRM or GIC. And so now it's like a retained root with like a millimeter or two of restorative material as the seal. Now, I'm just thinking about this scenario again. Would it be better in that stage just actually drill that coronal tooth structure until, let's say, the bone level, or maybe even deeper than the bone level? Because I've never done a root burial myself, so I don't know what the guidelines are to allow the blood clot and then the gingiva and everything to remodel over it. Is that how it works? And would that actually be better than actually leaving a restorative material out exposed?
Well, in theory, it would be better to bury the root because, of course, if you have restorative material, then it's very difficult to keep that clean. It's like food impaction. We all know those cases where you've got root caries and things like that. And often these patients, they do have root caries. That's why you're doing the palliative endodontics. I mean, if it's restorable, it's not palliative. So what happens is you end up doing a root burial. It makes sense because by doing a root burial, then they don't have to worry about keeping it, the dentine.
And so what are the guidelines? How much do you remove the tooth structure when you're doing a root burial? Like, are you going like subcrestal? I've never done it before, sir.
You just need to go at the alveolar crest, and you need to be able to stretch over the gingiva, over the root fragment. I mean, this isn't something I do, obviously, being an endo, but it's a max fax kind of oral surgery. They incise the periosteum because the periosteum keeps the gingiva stiff, can't drag it over. People who do this are very skillful at their incising the periosteum, and just, it's a bit like an oral antral fistula repair kind of scenario, the same kind of idea. The gingiva comes all stretchy if you incise the periosteum.
That's what I thought, but I'm just glad you've done that for, and it's important we mention that as an option for very niche patients, that we can't cover all the scenarios, but in some patients like that patient I described who's had the history of radiotherapy, that makes a lot of sense.
Here's another one.
Go on then.
Root amputation. Don't forget about that as an option. Some patients with, resorption on their mesial root of a lower 6, if they need to keep that tooth for a few more years, let's do the root canal treatment on the distal root and get the root amputated on the mesial. As long as it's not, if you've got that crack going into the distal root, then it's game over. But what I'm saying here is, again, you have to justify the need to retain the tooth. If the patient's that age, you don't want them to have an implant failure, you want to joggle the tooth along. So I am recommending root amputation in a few cases, again, niche patients.
I do about one a year of root amputation. It's very satisfying and totally has a place, and going in line with everything we've said. Quite often it's a molar, or even a second molar is the most recent one I did. Access can be tricky, but it's very rewarding to do that kind of a longevity-based treatment, right? We were just summarizing the different causes of concern whereby you think, okay, we definitely need to go down, have that consultation with the implant, let's plan that. What are the things that would make it a palliative endo rather than, okay, let's give this a really good shot?
Okay, so the obvious one is the root fracture, the split tooth, where you can basically you can't restore it. The structure's gone. The other one is I look at pericervical dentine. So pericervical dentine is what determines longevity. Again, that's a call for the prognosis of the patient again. Like if they need the tooth for 2 years, maybe that's enough. If they need it for 25 years, then probably it's more of a problem. So pericervical dentine, I always encourage all dentists that I'm teaching to write a note in their radiographic report about the pericervical dentine state, as in like tooth looks restorable, pericervical dentine is adequate, or tooth looks very heavily accessed or heavily treated, pericervical dentine is inadequate for longevity. Sometimes you're saying that to patients. So pericervical dentine to me plays a role in whether again, it depends on the patient's prognosis and how long they need, but quite a lot of the time I'm going, look, it's not really worth it because it's so hacked up and treated previously that we better get on with something else. Again, an opinion to look at something else, but if you really want to save that tooth, I know that it's not got a good longevity, but if you come, and that gives them the opportunity, again, from dento-legal perspective, they haven't signed up on the day, they've gone, got your quote, got the ideas, you've given them an exit strategy to go on and get the implant or the replacement. They've gone and done that and gone, that's not for me, I want to go back and get this tooth saved, even though he said the longevity was not as good. And dento-legally, you have that, it's the consult, they went away, they got another opinion and came back, and then you're all good to go, even if it's only a short-term option. And it's important to, again, explain others. That's why I love consults now for every patient. I rarely start treatment on the day because basically it just gives them that cooling off period of going, look, I don't want to do it, I do want to do it. If they're in there on the day, the tendency is just to get their sign up on, get going because they took the day off work or they rearrange all their meetings or whatever they're doing, and then they go, I should have done something else. So it gives them that cool off period just to think about it. So that's one. So pericervical dentine and basically longevity and things like that. Yes, there's not actually that many cases where I straight up recommend extraction.
The nasty crack and the lack of tooth structure is pretty much summarizes the worst of them. Even in the resorption, it's a lack of tooth structure problem, and we have a crack problem where it looks like you have ample tooth structure, but the crack is so nasty that you know that the prognosis is not going to be so good. And I think some of the main questions I get is, can we do more podcasts about cracks and stuff? So can you give us some guidelines of, what kind of cracks, what visual features or tactile features? You mentioned a imaging feature, which is fantastic, about seeing that Pac-Man bite. I love that. Any other features of cracks that you can describe, either clinically, tactile, or imaging, that point towards a poorer prognosis?
So we talked about vitality, that's
one.
right. Yep, that's another one. We talked about depth of the crack on the CBCT. The other one I look for is the occlusion of the patient. So, they're totally biting on this tooth all the time. The chances are this tooth is very cracked. Things like that. Their habits. Because again, even if the tooth is cracked but not severely now, if they crack it in 4 months, that's not ideal. Because so you're looking at the occlusion, history of cracks, previous restorations, and what they look like. So are the composites all smashed up and ditched? And also which teeth So a great example of this, I had this really lovely youngish, she must have been like 30, maybe 32, 33, lawyer in the chair, and I looked at her teeth and they were all cracked. And I just said, you're a stressed out lawyer lady, aren't you? I mean, it's just so sad. You're young and your teeth are all cracked. Like I was treating all her cracked teeth, but she had premolars that were cracked, restorations that were absolutely smashed up, and she wasn't an old patient. So you have to look at the previous restorations, whether they're cast and they're really smashed up, because that's a really bad sign, whether they're direct restorations and the age of those restorations. So how long ago did you get the restoration done? Oh, like 5 years ago. It looks terrible. It's like they are smashing their teeth. So again, if you're looking at cracked teeth history and prognosis, you want to consider their history of their general dental condition.
On the dental condition, Omar, tell me if you agree or disagree with me here. When I look around, we do a scan, we get an image of the patient, like an overview, right? And if I see that this patient may be older in their 60s and they've got like lots of MOD amalgams, which like with mostly like stained cracks, which look to be in enamel, that is a better scenario than the patient who's got tiny restorations or unrestored and got virgin cracks, okay? That for me is the more dangerous patient than the one that's got heavily restored but smaller cracks.
Correct. Yeah, that's it. Because the restoration, I know it sounds a bit strange, but it acts like a little stress breaker in the sense that you might get a mesial or distal crack, but you may not get an MOT crack. It's kind of like, the crack has to actually go through the entire restoration and the rest of the tooth. Whereas if you have those cracks in virgin teeth, it tends to make you think the patient's really clenching. I mean, you've cracked a virgin tooth. That's actually quite bad. Also, the fissure pattern of the second molar is a problem. It's a W shape. The crack just passes right through the whole tooth, and it's closer to the TMJ. So you basically end up with that loading of the joint. But again, you look at the patient's wear and tear on the teeth and say, look, I really think you're smashing your teeth up. You really need to have a splint. And sometimes I'm even offering them stress therapy, like go and read a self-help book, and that person at work who's annoying you and making you do this, don't let them annoy you. Honestly, I actually talk to them about stress and say, look, I know you're caring for someone who's sick sometimes, and that's going to be really hard, but don't let that affect your own teeth. It's already hard enough what you're doing to look after this ill person, but that's not going to help if you have damaged your tooth and you can't help them because you're a dentist or something like that. It's not going to help them if you're in pain from toothache. You won't be able to care for that person. So really just separate the two things and work on that stress as well, because there's always a reason why patients have pathological wear on their teeth. It's essentially pathological wear from mental health issues to clenching to grinding to stress and all of those kind of things. So really, that's a really important point. But trying to manage that stress, because people say, oh, get Botox. It's like, yeah, but that's just putting a Band-Aid over the thing. I mean, the actual problem is the stress that from whatever the stress is. Try to manage that. I mean, you can't eliminate it sometimes, but manage that stress as much as you can. And also maybe do the splint or the Botox or whatever you want to do. But like, you can do something. Your health is within your own control also. It might be only 50%, 25%, but some of it's within your own control.
Omar, I've just popped up.
Yeah.
I popped up a nice image of a crack for us, so I'm going to describe it for the Spotify listeners. We removed the amalgam, and it was like MOD-ish, lovely, nasty, stained crack. So again, stained means bacteria is able to get inside. It's worse a prognosis. But in terms of there are cracks that are a bit more delicate in terms of appearance, and then those that are nasty. This is very much, in my books, a nasty one. Would you agree with that?
Yes, I totally agree. Probably necrotic as well, isn't it?
Yes, and so is this one, without even accessing the pulp chamber, are you thinking, okay, this is the either palliative or, have that consultation and plan for implant future? Or, are you surprised sometimes by accessing into the pulp chamber and seeing actually it comes to not necessarily a halt, but it becomes not stained anymore, for example, or it kind of stops a few millimeters subgingival? What are you thinking there?
I would say actually, in my experience, generally the crack ends up a bit worse than I was hoping. And with these kind of cases, even if it's necrotic and it's stained like that, if you see a crack and it's kind of going down the root and you cannot see the absolute end of it, it's going to be way worse than what you thought. Now, that's the problem. Again, you would take a CBCT and go, look, there isn't a defect right now, or there is a defect. If there is, obviously, probably take the tooth out or recommend an opinion. But if the tooth doesn't have a defect in the bone, then you might consider something, because I guess the best way of visualizing a crack really is use of CBCT in the bone defect, because you can't see beyond the orifices. You're not going to drill all the way down that root to find out where the crack finishes, and if you do, it's just removing structure, which we all know is so important for survival. So this is where CBCT is absolutely important, because you've got your clinical, it goes into the pulp, yes, I can see the crack, but does it go into the pulp and then kind of stop, or does it just go down all the root? I tend to find that in these cases case is exactly like the one you're showing, I would be hoping for it to save it, and my heart would start sinking away, and I'd be like, this is going to be gone.
I know I'm putting you on the spot here, but as a percentage, what percentage do you think that look like this? Obviously, ignoring the patient occlusion, ignoring patient age, just appearance of the stained crack going mesial to distal. Would you say that actually we end up doing the root canal and, it's a job well done, versus I go in and I'm bringing the patient back up and saying, look, I've dressed it, but you're going to have it out?
I would say it's probably getting towards the 20% range. Not many. And again, you have had that discussion. We've all got this in our mind of like, how badly does this patient really need to hold this tooth? And sometimes it's like, oh, they'd do okay with an implant. Oh, they wouldn't do, then you start going, well, I really need to hold on to this tooth. And, provided all the other red flags aren't with the, the periodontal defect and stuff, you would try and save that tooth. And you'd justify it in your notes and say, look, the patient is not going to be a good candidate for implants, or maybe has had implants that have failed. It's another one. It's a first molar. We really need to hold that tooth. That's so important for this person, and they've had implant failures, so I'm going for it. You can do that. You can say, like, that's the reason why I'm going to totally go and do this, and as long as they're on board with that, I can't see anything wrong with trying to do that, as I said. But you do have to have the not split down the middle and the periodontal defect there, because then it's going to work against you.
I picked a nasty one for you. So those who are listening, maybe you want to catch the visuals on the app to see the image and almost talking points there. I had so many questions, but in the interest of time, I'm just going to just say, I think something that's really important to mention here is the whole thing about success versus survival. Can you explain to dentists, remind us about success versus survival, and then what is the data, implants versus endodontic treatments, when we look at those characteristics of success and survival?
Well, it's an interesting point, and my colleague that I work with in Crow's Nest now, she's done a few talks, and I like to talk, so she went through it with me, and she brought up some interesting points that I didn't bring up before. So success and survival. So success is very much endodontic healing of the apical lesion, but it has been in the research modified with a few ways. Like some people even don't quite classify them the same way. So some of those people call retaining the tooth success, but that's not success. Success, in how I understand it in endodontics, is essentially healing of the apical disease radiographically or on a CBCT imaging success, and that's the traditional way of looking at it. Survival is just the tooth is there. And so the implants are assessed on survival generally. There is a success criteria with implants, but it's quite loose compared to the success of root canal treatments, because root canal treatment success is actually pretty reasonably hard to get. I mean, especially if you use CBCT. First of all, we need a patient who's going to heal. Second of all, we obviously need to do the endo really well. And third of all, we need the time to elapse for the patient to heal, whatever that time is. I mean, many studies say within 5 years, but there is research showing that it takes 20 years for the root canal lesion or the endodontic lesion to heal. Malvern study. So there are those cases. And so what I'm trying to say here really is that success in endo can be often difficult to achieve. So as I've got more experience as a clinician, I've more got away from worrying about the little dark area, although I'm trying to heal that. Again, it's one of those things. I want to do both. Of course, I want to do both. I want the patient to have the tooth. That's their benchmark of success. That's survival in my book. But I also want the lesion to heal, because we want to show pretty cases in our lectures. No, we just want to make sure that the patient's happy and everything's going to plan and it's beautiful, and that makes us feel good for the day, because at the end of the day, it's all about patients feeling good and ourselves as well. But like basically aiming for success as the first point is often a difficult one to satisfy because of the time it takes to heal or the difficulties of the treatment. So then I default back to like survival a lot of the time and say, look, the criteria that came up a number of years ago was called asymptomatic and functional. And I liked that kind of terminology because it gives us a nice way to segue in, and we're keeping the tooth there because of this. We need to keep the tooth there. It doesn't matter if the lesion takes 3-4 years to heal. It's going to heal. It might heal. It might take a long time to heal. We know that from research. But what I'm trying to say here really is that it's really important to start with the focus of keeping the tooth. And if the patient's not in pain and you've kept the tooth, then that is you've accomplished something quite good for the patient. Asymptomatic and functional, I like that, because if you talk about survival, you're saying, well, they could have a draining sinus tract surviving. It's like, yeah, it sort of isn't what we're going for here. Or they could be every now and again, I have to take antibiotics because it swells up. That's survival, but that's not what we're looking for. We want the patient to go on holiday and not be worried about the tooth. That's the way I look at it.
That's a very real-world metric.
Yeah. I want the patient to go on holiday and not be sitting there worrying about whether their tooth might be bothering them and they have to go to a dentist and take antibiotics because that's what they do. And if they're having to
do things on holiday, Omar. Always on holiday.
If they're having to do something in their life to keep themselves out of pain or stop the swelling, or that's not asymptomatic and functional, because survival criteria would say asymptomatic and functional says the tooth is still there and the tooth is not bothering them at all. So I like that criteria.
I love that as well. I'm going to write that down. Asymptomatic and and functional, I think is a really real world way of looking at it.
Yeah, I like that. And so implants, again, when I was just talking to you about implants, a lot of the research is done on survival of implants. And the problem with that is, first of all, implants are placed often by experts in the field, whereas endodontics often done by dental students, dentists, anyone who's in the study. Then the other thing is implants just aren't placed in people who are going to be high risk for losing the implant. If you've had 5 implant failures, they're not going to use you in a study for the 6th implant. Whereas root canal treatment is a go-to whenever there's a problem. Like unless the tooth split or those things we talked about. So you're going to get a bias towards implants looking better because first of all, the criteria of survival is basically the only criteria. There's a successful criteria, but it changes. With endo, it's harder to get, say, success than asymptomatic and functional. And then survival, again, with endo is easier because it could be a sinus tract and all that stuff. So basically, if you look at them head to head, they have a very similar survival rate. I think the last time I looked at this was quite a while ago, and it was a King's College study. Shannon Patel, he was doing single visit endo with a 1-year follow-up. I believe there's been more research on that paper. And he was showing that his success rates for root canal treatment on incisor teeth was high, like in the sort of 100% sort of level. But as you got towards the back of the mouth, it was dropping to around 75%. And then implants, if you look at them, they're the same. We were looking at obviously success of endo in his CBCT 1 year later. A small sample size. It's his practice cases for a year. And then if you look at survival of implants, that's in the sort of similar kind of level.
They're both similar, then it just makes sense that, it goes back to the very first point you made, right? If endo is on the table, it's feasible because it's got enough tooth structure and the crack is not so nasty. And even if it's looking a bit dubious, then there is still so much to be gained by getting some survival and allowing the patient to have an implant later on in life than first up. And one thing that we actually didn't elaborate on, but the whole thing about using retained roots and doing endos on them to keep them in the mouth, we sometimes forget because what we think is, let's take out this retained root, then do a socket graft. But actually, just work with that retained root, because if the patient's going to walk around with nothing there anyway, then you might as well do a retained root and then keep that PDL, keep everything, keep the bone preserved there, rather than putting artificial bone or whatever for the future. But again, I'm no implant dentist, I'm not the person for that. But Omar, thanks for the brilliant overview today. We covered a lot of ground, a lot of different topics, from root burial to success versus survival to different characteristics, red flags. Is there anything else that you would like to leave us with before I ask how we can follow you, how we can learn more from you?
So I've got Instagram and Facebook at Specialist Endo on Instagram, and Facebook's Specialist Endo Crow's Nest Clinical Hacks. I've been doing this teaching online for, it's been over like 12, 13 years now, and it's been so fun. We're running courses in Sydney this year. I've got one in Melbourne. I'm hoping to come to the UK soon at some point, and we're looking at doing a bit of lecturing maybe in Taiwan later in the year, so that's going to be super exciting. So we've got lots of things planned for this year. The other thing is just breaking news for me is that I'm now opening my own educational-based dental practice with the kind of concept of creating a facility where specialists work there, like me and my colleagues, and we provide opportunities for people to come and observe cases where they're set up with screens, and also there's a facility for educational courses within that same practice. So that's something really exciting that I've just come up with in the last few months. And like the idea is to create like a dental hub where people come, learn, and even if you've had a bad day at work, come in and talk to me about your bad day at work, and we'll have a coffee and discuss why it was a bad day. And because that's what I would have wanted when I graduated. I would have wanted someone that would take me aside and go, look, it gets better. And all those discussions that you can have with your younger dentists or even older dentists who are having a bad day, it doesn't matter. So basically that's the exciting news for me. And so thanks so much for having me. It's been really great to talk to you again. Our previous discussion about, I believe it was files and all those interesting things.
Be more efficient in endo. Thank you so much for your time, Omar. Honestly, absolute superstar in everything you do, and you're a Mr. Motivator, man. You literally are a Mr. Motivator. I think I love talking to people like you who, we talk about the clinical, we geek out, but you bring the world and life experience and philosophy into it, which I'm always a big fan of that. I'll put all the links for Omar's programs and his Instagram account and his Facebook page as well. And as soon as you have something that you can give me about any UK visit or any other links I can put on, people always ask me, where's the link for this? And I'd love to put it all in the show notes. So please do send me that, Omar, and I'd love to distribute it to all the Protrusive. From us, thank you so much for covering these varied themes. I had a lot of fun.
Thanks heaps for having me, and have a good day.
Well, there we have it, guys. Thanks so much for listening all the way to the end. I wonder if it means now I need to record the same episode with an implant dentist. Do you think that would be necessary? I don't know, because all the implant dentists I respect would probably agree with 80 to 90% of what me and Omar was saying in this episode. And to get a dentist to agree 80 to 90% with another dentist, that's a pretty good thing, right? Now, of course, in this episode, there was some bias because it's an endodontist we're talking to. They live and breathe endo and saving teeth, but the message is a good one. As restorative dentists, first and foremost, we preserve vitality. And if that's not possible, we preserve the tooth and the PDL for as long as possible. And if that's not possible, we want good survival and success of our implants. And ultimately, we want the patient to win. And that is at the crux of healthcare, my friends. Now, if you're listening on Spotify, Apple, etc., please do hit that subscribe button and share it to your WhatsApp group, share it to your colleagues if you found it interesting. We've got hundreds of episodes in the backlog. If you're just discovering Protrusive, where the hell have you been? Welcome. And of course, join the Protrusive app, www.protrusive.app. The Protrusive Guidance app is the home of the nicest and geekiest dentists in the world. Get 80% of the quiz. So scroll down if you're watching on the app, answer the quiz, and claim your CE credits. Our CPD Queen Marie will send you the certificate, and every quarter she'll send you an update of how much CE you've completed Protrusive, and then annually she sends you like a big annual summary as well. And yes, it's all tax deductible because it's dental education at its finest. Thank you to the thousands of dentists who've joined us on Protrusive Guidance. It is so beautiful, the community we've created. And with that, I'm going to say goodbye. I'll catch you same time, same place next week. Bye for now.